Good morning, everyone. It's 8 o'clock, so I think we'll get started today. Welcome to Provincial Stroke Rounds. My name is Julianne Kavanagh, and I'm the Regional Stroke Program Coordinator with the Southeast Toronto Stroke Network, based at Unity Health Toronto, St. Michael's Hospital site. Today's presentation is on health equity in stroke care and will be presented by Dr. Atif Zafar. We have people joining from right across the province today. So before we get started, I just wanted to review a few housekeeping items. We will be sharing the slides from today's presentation after in an email. And just to let everybody know that we are recording this presentation and it can be accessed through a link provided in the follow-up email you will receive. Please check that your microphone is on mute. All microphones should remain on mute during the presentation unless you are asking a question. We will have an interactive component that will be held during the last 10 to 15 minutes when we will have a question and answer period and hope to hear from as many of you as possible. So please type your questions into the chat section and I will be monitoring it. For those of you that are sharing a Zoom link, we ask that you please complete an attendance form. As well, please complete the evaluation either online or fill out a paper version that was emailed to you. You can send the signed attendance list and the paper evaluation in the email listed at the bottom of the poster. Certificates of attendance have also been emailed to you. Please fill in your name and keep this for future reference. So without further ado, I want to introduce Dr. Atif Zafar. Dr. Zafar recently joined St. Michael's Hospital in August as the medical director of the stroke program. And as of this January, he also took on the role of medical director for the Southeast Toronto Stroke Network. Dr. Zafar is a dual board certified and a diplomat of the American Board of Neurology and Vascular Neurology. He completed his residency at the University of Iowa Hospitals and Clinics and a stroke and vascular neurology fellowship at the Cleveland Clinic. Prior to moving to Canada, he was the director of stroke and cerebral vascular program at the University of New Mexico School of Medicine, where he built an efficient academic stroke team and a comprehensive stroke program with a busy vascular neurology fellowship. He has been the co-PI of various NIH grants for stroke and cerebral cavernous malformations. He was an executive committee member for the Brain Vascular Malformation Consortium, a part of the National Institutes of Health Rare Disease Clinical Research Network, and currently is part of the Scientific Advisory Committee for the Angioma Alliance. Thank you, Dr. Zafar, for taking time out of your busy schedule and agreeing to speak today on this important topic.
Thank you, Julianne. Thank you, everybody. Nice to meet everyone, and thanks for your time. So I'm going to go, this first slide I have to show you for the evaluation. I'll come back to it at the end as well. So the topic I'm going to go over today is an interesting topic. I would call it a relatively new topic in the stroke world. If you look at the literature, it's there in stroke. In the last 15, 20 years, there's some sparse literature out there, but it has not been done in a way to make it look organized. And in the last few years, I've been working on it with my group as well, and looking at the publications coming out, and we've been doing some work on our end. And, and I want to share with you.
Thank you. I don't know if there's volume.
I want to share with you some of the things that I've learned on the way, some questions that have come up that we'll have some interactive discussions on it, and we'll share some of the research work that my group and I have done in the last couple of years as well. So I have no conflict of interest, no bias related to the content that I'll be sharing. So the objectives that we have that we're going to cover today will be inequity in stroke care in North America. Is it even real? Are there gaps in these areas? So we're going to go over that. We're going to go over impact of geographic stroke inequity, and come up with having an interactive discussion on figuring out potential solutions. I'll share my perspective on this. And then we'll talk about the racial and the socioeconomic disparities in stroke, and if there are potential answers to the problems. I've invested a lot of time and energy in this arena. There was a reason why I chose to go to an underserved state in the US and gain some experience there as well. And I would love to share some of those things with you. So like for every stroke talk, we go over the background. We all know it's one of the leading causes of death and disability in the world and in North America. One of the big issues that comes up is that the acute stroke treatment, which does make a huge difference in the patient outcome, we still struggle that only less than 15 to 20% of the patients get the acute treatment. And then there are a lot of costs associated with acute stroke, with stroke disability. 2.7% of the total healthcare cost in Ontario
Over to me.
goes
Yes, I was
for
there.
stroke care. And then as the emerging endovascular treatment has kind of become the mainstream of acute stroke care, we're seeing that we're struggling with some of the challenges that come with it with regards to allocation of resources and patient access to healthcare. And then the lack of neuro resources, which range from having a CT angio even, and then having, neurospecialists or radiology specialists that can review the images, live, having the basic infrastructure with regards to, imaging and whether it's CTA or MRI or CT perfusion, leave alone the endovascular suites to a lot of the patients. So we're going to go over some of these things, and I'll be happy to kind of answer questions at the end. And if there are some interactive points, feel free to interject. I'll start with this slide, and this is something that really inspires me, as a physician, as a healthcare provider, as a human being. And I would like to spend some time with you guys over this slide. If many of you might have seen it already, but if you look at it, and I myself, who practiced in the U.S. for about 10 years, this was one of the discussions we were having at the state level where I was, and at the NIH level where I had a chance to interact with my colleagues. If you look at it on the left side, there's equality, and then on the right side there's equity, and a lot of times as human beings, as individuals, as caregivers, we question what we are doing. Are we doing it right? And if you look at the left, really, left side of the picture, the goal is that we want all the individuals in this family, for example, to be able to see the baseball game. We don't want one of them to have, we're not thinking about giving one of them a VIP box and the other one, a regular view from the stand. Our goal is to provide all of them the ability and that they can see the baseball game at an equal level. And to achieve that, sometimes, as we go towards the right-hand side of the picture, we have to do things differently. And that's something that, being involved in healthcare leadership in the US and as a medical director now, I think these are the things that we sometimes have to think about twice as we're making those decisions on how we're going to allocate resources at the small level when I'm involved, and at the larger level where many of you are involved. But really, if you look at the right side of the picture, we're allocating resources, if you're calling these boxes as resources, to be frank, in not an equal way, but an equitable way. And what we're achieving in the end is everybody can see the baseball game in the same way. So by allocating these resources in a different way, in a planned way, we're achieving a really standardized outcome. I've shared this with many of my colleagues, in the healthcare, and we've gone over and discussed these slides. So when you go in depth as a healthcare professionals, as care providers, it does it does make us question ourselves on how we're doing things, and is there a way to change it? And that's what inspires me to continue to do my work in this arena. And I'll be happy to share to hear your perspectives as we move forward. So what we're going to do in the next few slides, and some of those slides I'll go over, kind of quickly because I don't want to bore you as well. But the idea will be that I want to share with you some of the research that's out there, and then we'll go over some of the work that my colleagues and I have been doing the last couple of years in this arena. I've got some grants as well in this area, and at the end we'll get your perspective on this. If after going over these slides, we can have a buy-in from all the stakeholders, from all the viewers that yes, there is definite inequity in stroke care, I think I will consider that as a great accomplishment for myself. Now we'll go over some other points like sharing our perspectives, talking about some of those things on what the solutions are. But as you'll see, there's not a lot of literature out there, so that won't be evidence-based in the truest of sense. So if you go over all the literature that's out there in the stroke arena and in health equity, you'll see that these are the three areas. And many of you who are involved in stroke will, as you go through it, will acknowledge that these are really the main issues. Geographic equity or inequity, racial inequity, and socioeconomic inequity. And we're going to go over some of those. So we're going to go over a few papers. There's not a lot out there in the last 3-4 years, but we'll go over the big ones that have come out. So one of these came out from Denmark, one of the really good, and I consider a pretty advanced healthcare system. I spent some time in Scandinavian countries, specifically at Karolinska in Sweden, to study some of those things, quite many years ago, and I love this paper. And if you go over this paper, you're going to see that it's done in a very robust way. So I wanted to share it as a first manuscript with you. We'll go over it briefly, but really what it looked at, it was the socioeconomic status and the acute stroke care. How does it impact? Is there inequity or inequality? There's gap in there. It was published in 2019 in Clinical Epidemiology. Dr. Sokard was the leading author in this. They looked at individual patient data that they have in most of the Scandinavian countries. They looked at between 2004, 2014, spent the next 4 or 5 years deeply analyzing these results and finally publishing it. Really what they found was that even though the healthcare is completely free in Denmark, when they compared the high family income with the low family income, there was a clear association with statistical significance in their results, that the guidelines recommended stroke care, which they have around 16 performance measures, starting from the acute to the subacute to the stroke follow-up, and those performance measures kind of define how they're going to grade their acute stroke hospitals. But they found that within those hospitals, with this group of patients, there was a disparity, and low family income was negatively associated with the fulfillment of the 14 of the 16 performance measures. Many of them achieved statistical significance. Many of them had some trend, but 14 of the 16 had differences that showed that the low family income was on the receiving end or was on the suffering side. So phenomenal results to show that we're not doing our job the way we're supposed to, in my opinion. The second manuscript I'm going to share with you briefly is a study that came out from UCL, University of College London, and it was published in Lancet 3 years ago. The socioeconomic disparities in the first stroke incidence, and then the quality of care associated with that stroke incidence, and then the eventual survival of those patients. It was a registry-based, not an individualized study. It was a nationwide registry that was reviewed 44 million adults in England. It ranged from 2013 to 2016, so they looked at that time period. And really, the final results were the patients from the lowest socioeconomic groups had first stroke at a median of 7 years earlier than those from the highest socioeconomic group. They were less likely to receive 5 of the 12 care processes that were standardized or that have been standardized in the UK, and it was associated with a 26% higher adjusted risk of 1-year mortality. So pretty significant numbers again in this study published in Lancet. The next study we're going to go over, it looks not at the true socioeconomic disparity, looks at the urban-rural inequities in acute stroke care and the mortality associated with it. This was done in the US. One of our colleagues at Dr. Maddox at Washington University. So what they looked at is this NIS registry, which is accessible and available to pretty much everyone in the US. It's one of the largest inpatient registries in the world. And what they did was they looked from 2012 to 2017, and then they divided the patients, that were treated at the rural centers, compared them to the urban centers. And what they found was that the rural patients with strokes were less likely to receive TPA, the intravenous pharmacological therapy, or the endovascular therapy, and had higher in-hospital mortality than their urban counterparts. Now, a lot of these inference and these results may sound pretty raging and pretty strong, but a lot of us who are already involved in the stroke care probably will not be surprised, because we experience a lot of these things on a day-to-day basis. This next study is, as you know, a lot of the studies have been published with, cardiovascular disease or cardiovascular disease burden as their title, but really it incorporates the cerebrovascular risk factors as well, because they're pretty much the same for the most part. So this study that was published in Current Cardiology Review quite a few years ago, 5 years ago or more, looked at the disparities in the cardiovascular disease risk in the US. And Dr. Graham was the leading author. All it did was review a lot of the literature that was out there in the last, preceding 10, 15 years. And as we all know, there were some racial and ethnic disparities that were discussed in these papers. We all, have read those in many of the other prior publications. So African Americans twice as likely to have a stroke in the epidemiological studies so far being done. And we have similar literature in Canada with regards to Canadian Africans as well. The vascular risk factors are more prevalent in pretty much most of the minorities, if not all. And then obesity, along with dietary and drug-related issues, were more prevalent in the minorities and the underserved population as well. So, if you will find a few more literature, like there's one positive literature in North America that shows that maybe the vascular risk factor trend has not been going up, but a lot of those analysis and those works were done from studies that looked at the data from 2002, 2005 to up to 2012. But as soon as we start analyzing the data beyond that, 2013, 14, 15, 16, we've come to realize that trend may be changing again in North America. And that's some of the work that my colleagues and I have been doing the last couple of years. But before I go there, I'll share some of the experiences that I had in an underserved state as well. So as a stroke provider in an underserved state, one of the frustrations that my colleagues and I were having were that as we were one of the only sites or one of the main sites that was transferring patients in for pretty much all major strokes in the entire state and some of our other regional states, it was pretty clear on anecdotal basis for us that every time we were accepting patients from the indigenous population, which was living in these specific areas, the time it was taking for them to reach to us was really, really high. And we knew the logistics were the limitations, but we wanted to look at it. So we just looked at the last year's data just before I moved out. And you know, in about for 7 months worth of data, we found that a cohort of 35 patients who were transferred for mechanical thrombectomy, 7 of them were minority patients, again, very small number, but we looked at the metrics, the transfer metrics and the in-house metrics. We presented that at the Society of the Neurointerventional Surgery last year. And we're continuing to gather more data, you know, on this. What we found was that the prevalence of the vascular risk factors, which was not surprising in Native Americans or the indigenous population, was noticeably higher. The Native American patients had similar functional and neurological outcomes after thrombectomy, was what we published. But if you look at the results, for sure there were trends that were showing more time to treatment in-house, pre-hospital, and obviously this was a wake-up call for us that made us improve our in-house numbers as well. But you know, there's these logistics system issues that when you know that you're going to accept a patient from a certain area where the helipad's going to take longer, and then the patient's going to come in here, you know, in 4 hours, for example, you pretty much know as a neurologist, you're going to see that the stroke infarct will probably be already there, and you become a little bit slower. And then, you know, so those are the things that are pretty much hidden a lot of the times from the true literature, but we continue to experience them. So again, there was no statistical difference in this small cohort that we looked at, but in the two groups, the median time interval from last known well to the groin puncture, from last known well to reperfusion, was different. These were not statistically significant, but they were definitely showing trend going against the indigenous and Native American population. The mortality was 14% in the Native Americans in the indigenous group, and the 4% in the comparison group. Again, not statistically significant, but enough for us to start making changes in our program. Another study that we did, which required a lot of you know, startup fund that we had to gather from my hospital and from some donors initially. But what we wanted to do was we wanted to look at one of the largest databases that we have in the US, which is an EMR database of 600 US hospitals, about 62 million patient records. And it took me a couple of years to be able to gather that data and find the funding for that, but we were able to get that. We were able to look at data from 2009 to 2016 for patients 18 years and above. We had a group of statistical and epidemiological experts who were working with us in creating some of the modalities and the methodology of the study with the Cerner group, which is the second largest EMR group in the US. So what we looked at, we wanted to look at different things, and you know, I have some publications in different arenas regarding neuroinflammation and stuff, but we also looked at the vascular risk factors, the cerebrovascular risk factors in patients 18 years and above from 2009 to 2016. And I'm not going to go in too much detail, but when we looked at the different racial and ethnic groups, we were able to find some statistically significant results. So although all races showed increments in the last 4 years in our study, which was 2012 to 2016, the indigenous population, the African Americans, the Hispanics showed exponential increase in those risk factors compared to the Caucasians. There was an uptrend, and this was all statistically significant. Again, in the last 4 years, all ethnicities, including the Caucasians, which was you know, alarming, showed the increment and then when we looked at it and we compared the control group, which were Caucasians in our study, there was statistical difference when we compared them with the minority as well. I mean, obviously there were limitations to this study. It was an EMR database, so it relies heavily on how the providers are incorporating the data. A lot of times the racial and the ethnicity information demographic is not extremely reliable based on our experiences. So there were definite limitations in this study. And you know, I'm not going to go into detail, but just graphical representation, you can see that there's, you know, uptrend in the prevalence. And then if you look at it in the preceding years, this uptrend was not statistically significant as much, which is you know, published. If you look at most of the studies that are published in 2012, 2010, we were very happy that things are coming, you know, going in the right direction. And as a public health entity, we're doing a good job. But now, in the last 8 years, we've seen some uptrend again. Again, we're not going to go up, you know, go in detail on this for the sake of time, and I'll be happy to share some of this work with you. I'll share my email at the end, and then some of those references are were already shared in these slides. So we wanted to kind of authenticate it a little bit. So one of my fellows who's at Emory right now, and my mentor who's at Cleveland Clinic, we were able to collaborate, and this work is still in its final phases for submission. Unfortunately, we just got a refusal from Stroke, but we'll be submitting it soon. We have presented at the American Heart Association, the International Stroke Conference as well, and we have really fine-tuned this data even more. We'll be submitting it in BMJ as of this week. But what we looked at is pretty much the similar stuff that we looked at the EMR database, and we looked at in the National Inpatient Sample Database that takes away some of those EMR biases, because the NIS, or the National Inpatient Sample Database, incorporates a lot of the data from insurance companies and things like that. So we kept 6 time periods. And again, I'll go over it quickly. There were similar upward trends for pretty much all the risk factors for stroke, and they were pretty similar to what we just discussed that we saw in our EMR Cerner database analysis. So by the year 2015, 2016, the indigenous population, the Native Americans, had the highest overall prevalence of diabetes, coronary artery disease, smoking, and alcohol use among all race ethnic groups. There were significantly larger increases in the prevalence of hypertension and smoking in the indigenous population in these time periods. So again, you know, we had these similar uptrends that we saw. Again, there are limitations even in the National Inpatient Sample Database. The racial information is not up to date or complete in up to 17% of the ischemic stroke patients. So that is a limitation. It was less so in our Cerner database, but there are limitations in all, you know, demographic limitations in most of the studies we do. So we were able to kind of show that there are racial and ethnic differences, and we were able to prove them. And there are other studies that showed the same thing. The socioeconomic and the geographic factors were not looked at this time, but now our group is interested in looking at that. So we're looking at the urban-rural divide in the National Inpatient Sample as well for the more recent population. And we'll be able to look at some of the geographic factors, because the National Inpatient Sample also distinguishes the tertiary large academic centers and the smaller centers. So we'll be looking at those factors as well in our future work. So far what we've done is we've gone over in the last 30 minutes or so to see if we can be all on the same page. If there's inequity in stroke care, whether it's geographic, it's racial, or socioeconomic. And we've gone through different studies that have been published, some of the work that our group has recently done. And I would say and I'll be open to your, the interactive discussions, that at least we can all agree that there is this inequity in stroke care, which is raging and which is really very prominent. Now, do we have the solutions? Do we have the answers? If we have all agreed that yes, there is inequity, and before I go there, again, a lot of those things you'll see are not truly evidence-based. I wanted to kind of give more studies and share more papers, but it will take more time. But I'll be happy to have interactive discussions. We have had some publications that have looked at the rural-urban divide with regards to mechanical thrombectomy and patient transfer flow that just came out in the last couple of years. But what I'll go over some of these things. As we move to the next part of our presentation, I'll go over some experiences to connect with you more. So as you know, there are geographic and urban rural inequity, right? We've talked about it already. But in the clinical sense, what it means is that when patients are coming in and they are candidates for thrombectomy, or there are patients who are candidates for TPA, how does our workflow, how does it work? How should it work? Are there ways where we can fix it? Is it ideal the way we have it? Are there easy solutions? And we all know as clinical, care providers and administrators, as decision makers, that there are huge gaps in there, and there are limitations that we try to kind of improve and bypass, but they're there. A patient that's going to go to a specific hospital, and if they end up having a large vessel occlusion, it depends on what imaging capability they have, how far away they are from an endovascular ready hospital. Same with slow transfers versus missed large vessel occlusions. As stroke providers, we all experience that in some of the sites where we say, yes, please transfer the patients, we know it's going to take 3 to 4 hours for them to come to us. And we know what happens in 3 to 4 hours to those stroke patients by the time they come to us. We know how their outcome is impacted negatively. Dedicated stroke units and neurocritical expertise, we all know it's published, it's in the guidelines, it's recommended that all these entities improve patient outcomes. How much we struggle, including myself as a stroke medical director, there's daily struggle for us to get a buy-in to make these type of things work, at the regional level, at the site level, but we know that they work. We have shown, evidence-based good outcome, but we struggle in some of those things. So, and then inequity of resources, of how we allocate CT angio, CT perfusion imaging to specific hospitals. So if I was living a little outside the GTA, the chances that I'll get an equitable acute stroke treatment, are they guaranteed or are they not? These are the questions I'm going to bring up, and then we'll go over quickly over some, my perspectives, my suggestions. Similarly, if I'm financially challenged and I am homeless, for example, and so the chances that I'll get equitable pre-stroke, post-stroke, acute stroke management, are they worse than grim? Are they equitable right now in the world we live? If I'm an Indigenous or Canadian American, African American, the chances that the ED I go to will have CT angio or I'll make it to the nearest tertiary stroke center on time. If I'm disabled or I speak a different language and I need an interpreter, will my stroke care, will it be compromised or not? Will it be delayed or not based on the system that we have as of today? And there are a lot of things that have already been published, right? The higher volume centers do a better job with regards to their procedural, their timeline. So the more volume you have, the well-oiled machine you become. So it's also challenging to kind of make every center, deal with the same kind of the disease burden, because we know that would be a challenge. And that's one of the things we all deal with. A lot of you as decision makers deal with. Hospitals with neurologists and stroke resources, stroke teaching, CT and CT angio. Which hospitals are better prepared to manage acute stroke patients? We know the ones with more volume and with more resources are. We also know that patients in rural areas often are the farthest from the tertiary centers. So are there gaps where we have to have strategic planning on where and what sites we're going to invest on to get them ready, not based on how they have done, but based on where they're located and how they will be able to cope with the regional population. And same is the case for access to the stroke prevention clinics, which is an issue. And before talking about the potential solutions, and I'll go over it in the next 5 minutes and then open the forum for interactive discussions and questions, I will say that based on my experience, 10 years in the US and now being here in Ontario, that it is impressive here. I mean, the way things are done, the way the interaction is, the way we've dealt with COVID here, I would say that as financially resourceful, my prior experience at Cleveland Clinic and UNM was, interactive discussions and the decision making, it has been impressive based on my personal experience, and it kind of shows how much gap there is in the US system. But at the same time, there are certain things that, because this is an area of my interest as well, that I feel like we can do even better than where we are currently in Ontario. And these are some of the, things I'm going to share in the next 2, 3, 4 slides with you. So geographically planned stroke sites, which have the ability and the capacity to build volume and provide expertise. So that's one area that requires a huge strategic planning, and not based on what we have, but based on where we'll be in the next 10 years. And that is, that requires a lot of commitment and a lot of ownership from all the stakeholders in coming up with those huge strategic plans. I see that we continue to do it at moderate and intermediate level, but I think that is one of the gaps, that would help balance this health equity gap that we have in stroke. The planned sites in future can be robotically managed by high volume centers as well. So the way the world is moving with regards to tele and there's when we plan, or if we plan on a long-term 10, 15-year strategy, we need to consider some of those robotic tele AI related models in there, which is just a matter of time will be here. High volume centers provide coverage to these outreach sites, and then the resource allocation, which is already done in a pretty nice way by having these regional sites in Ontario, but can be improved, in my opinion, to kind of give more responsibilities to the centers that are the tertiary centers. And then, more sophisticated, but that's something that's proven in publications. And I've published something where we had the mobile stroke unit as an ambulance with the CAT scanner and the TPA ability and a tele ability, that how financially and economically, if it's strategically located, it works. So mobile copters and ambulances based on the strategic geolocation. And now there's work going on in even having angio suites and infusion suites in those mobile copters and ambulances stationed in the strategic areas, based on the socioeconomic priorities, if we can't build a comprehensive center there. Other equitable acute stroke care solutions may be that having a CT angio and ability to get the aspect score, and the clinicians having the ability to do the NIH score should be the prerequisite to be a primary stroke site. So if you have a center that can't do any of those in the 21st century, and not having these least minimum skill set, in my opinion, is unfair for the patients who are going to those sites. So having that basic standard changed as we evolve. And then obviously that we're doing already the implementation of teleneurology and allocation of resources accordingly. So similar equitable solutions for stroke prevention, in my opinion, would be creating a network of physicians that include family doctors, geri, internists, neurologists, whose main focus is to provide access to patients on an equitable basis. And that is one of the bigger challenges that we see here in Canada, that just getting into the clinic has been a challenge, even as of in the age of today. As a second step, once we have that strategic implementation, the same group should be able to identify, using the innovative technologies that are already out there, and patients who are more likely to have a stroke can be filtered out based on the large epidemiological data-driven pools that we have created by World Stroke Organizations and entities like that. So those patients then become part of the stroke primary prevention program, so that these patients are not having stroke to begin with. The last one is about the potential solutions, in my opinion, about the equitable stroke recovery. One of the things that shocked me a little bit, more than in my prior experience in the US, was the access to the outpatient rehab. In our stroke world, and it's well published, that the sooner you start rehab, the sooner the patient's gonna get it, the better the outcome will be. And the earlier you do it, the better the recovery is, because the neuroplasticity is better. And overall, the standard that we have been able to achieve in Ontario is that after the patient's discharged from acute rehab, or if they go home, the access a lot of times to the rehab clinics is at least 2 to 4 weeks. I call that a golden period of recovery. And those are the time periods where we're missing out on, and that's an easy gap that we all can fill. And obviously having access to the post-stroke clinics. If somebody has a heart attack, the patient gets married to a cardiologist for the rest of their life, and they have a PCP and they have a cardiologist, and we still struggle in providing that access to our patients, and we want to sign off on those patients because of the lack of neurologists that we have as a system. And in the end, we need more robust databases, as I'm doing some of this work. And as you will, if you get time, review some of the literature out there, you will be amazed at how little we have on health equity or inequity in stroke compared to so much of the work that we're doing in the stroke world. Inclusive remarks. The urban, rural, the racial, and the socioeconomic inequities impact stroke care and outcome. We need to consider them everywhere, at every level, at the hospital level, at the system level, at the region level, at the provincial level, and at the country level when we're strategizing our stroke models of care. Awareness among healthcare providers regarding equitable care for patients and advocating for equitable care is imperative, because if you speak with the healthcare providers, this idea of inequity in stroke care or inequity in general, the awareness isn't there as much as it should be. Strategic planning should be based on equitable resource allocation rather than the current typical model of equal resource allocation. And then CT angio, NIHSS, having the ability to read the CT angio, having the ability to do that NIH stroke scale should be considered the basic requirement for all hospitals that are providing even the basic stroke care. And it should be the basic requirement in my mind. So that pretty much ends my talk. I would end with the same picture: equality and equity, and it's in my gym room, it's in my office, and it's a great picture. If you look at it, it's just a picture, but as a caregiver, if you look at it, it does give you second thoughts on how we're doing things and how we should be doing things without feeling like we're doing it in an unfair way, because this is really the fair way of providing healthcare to all the people we serve. And thank you again for your time.
Thank you so much, Dr. Zafar, for this thought-provoking and topical presentation. This was really eye-opening in terms of better understanding some of the inequities that are being seen in stroke care, and also to the gaps that exist in our current understanding. At this time, I would like to take the opportunity to open up the floor to see if there are any questions. One question that's come in, what would you say is the most significant way this understanding of inequities has impacted your own practice?
So that's a great question. I think one is getting inspired and starting to think about it, and being at the Cleveland Clinic, where we served a lot of African Americans or the Black community, and then in New Mexico where we served a lot of Hispanics, and that kind of was clear that you would see a lot of those things happen on day to day that don't get measured, just become part of the logistics system, and me being part of that logistically healthcare system was the inspiring part. And how has it changed the way I practice? I think one is every time I'm doing it, putting that conscious bias in my decision making to counteract that bias that exists in the real world. And that is when I'm interviewing for my new jobs, or when I'm making decisions based on where I practice, where would I go and where would I practice, and what will I do and what type of research. I have done many other researches prior to that, and was getting funded for that. But I want to do more work in this arena. So as a clinician, as a researcher, as an administrator, a clinical administrator, I would say in my clinical decision making, I try to change the way I practice. If there would be a bias in my mind that I'm accepting a patient from an area where it is geographically underserved, the patient's going to come late, I would try to be even more active, in that patient, so that I can turn the time around. So those are little things again, and then doing more studies, because there's lack of research right now. So building those epidemiological data analysis, and that's kind of. I don't know whether that answers the question, but that's the best way I can explain this.
Thank you. Another question that's come in is, Trina's wondering, have you seen the impact of primary care prevention for stroke?
Very good question. So as you know, if you look at the evidence, we fail to even start a baby aspirin to many of our patients as a primary prevention tool, right? As a stroke physician, I would say I don't have any evidence-based answer to that. I would say that when I started in New Mexico, I was the only stroke neurologist in that entire state. I was the first stroke neurologist and the only stroke neurologist in that entire state. And then we were able to build up, 6-7 stroke neurologists, 3-4 NPs, stroke fellowships. We had a research program. We had a $10 million worth of funding that came our way, and we were able to partner with underserved areas. When I came in, I had a waiting period of 18 months to get into our stroke clinic, which we were able to improve to about 72 hours for our stroke patients. And what we saw in our numbers was not for the primary stroke prevention per se, but I would say for patients with TIAs or for patients with a stroke, for secondary stroke prevention, we were able to decrease the number to half of the stroke recurrence in those patients. So just improving the access, being available as a resource for the system as neurologists, and improving the models of care, we were able to make a difference at a regional, at a state level. So I am confident that we can replicate that in the primary prevention model as well. But right now we perform so poorly, even at the secondary level. I struggle because some patients who see me after 3 months, 6 months, 9 months after the stroke, it's rare, unless they have an ICAD or some sophisticated, other moya, that they will be part of my clinic long term. But if they are, we know that we can make a difference because we will work with the primary care doctors so closely. So I believe it will make a difference. Do I have evidence? I don't think so for the primary prevention.
Okay, thank you. And there's been a comment in the chat box, so I will read that out. In addition to the above comment, you mentioned the rise in vascular risk factors, especially with Native Americans. I think we need to work more at the front end with supporting more Indigenous community-based and culturally safe screening programs, such as blood pressure, which improves access to primary care, thus potentially reducing risk for stroke. We are challenged with adequate funding, probably inadequate funding, despite these low-cost initiatives. Question: did you notice any such community-based programs reaching high-risk groups or screening risk factors?
again, great question. And I would say that it's a challenge everywhere. And I would say that at some hospitals, even in the US, we had a dedicated MRI machine for our stroke patients, but then we were the only site with that, and the rest of the most of the state didn't even have many of the state suburban and indigenous hospitals that serve the indigenous population didn't even have a plain CT scan. So it's a challenge, and if we have a challenge in the acute care models, then yes, there's a challenge in the preventative model. Now, there are certain things that have been done where we're creating mobile programs, like for example, the mobile stroke units that can be strategically located, which has all the infrastructure that's needed. And it doesn't only, when we did our, at the Cleveland Clinic, the mobile stroke unit stuff, we looked at the non-stroke related stuff and put that in our economic model as well, because we were able to save some of the patients who were on opioid overdose and benzo overdose, and able to reverse that and not take them to the ED actually. Same with trauma-related stuff that we're able to do their CT and X-rays in the ambulance. So there are ways of doing it. Is there an excellent model already there that I can give you an example of? I don't think so. I think, are there ideas that I have that may work, that involve innovative models, which involve in Internet of Things, that can be, for example, in Scandinavian countries, what they're doing in their underserved areas or areas that are geographically challenged is there are certain projects going on that there are, blood pressures can be measured ambulatory, and they are connected with the phones that they're being given in those sites where they have internet, and they have their capsule bottles. Every time they open the bottle, the report goes in that model in the centralized system, and if the bottle doesn't get opened that day, then a call or a text goes to the patient or that family, that please remind the family member that they haven't taken their Eliquis today. So I think the future will have more answers for us, because it will make things easier for us to solve some of these long-standing questions. I don't think there's a model already out there, but I feel like having mobile programs to remind and educate and fundings dedicated to those models worked okay in my prior practices in these areas. We were able to go and have educational sessions, blood glucose and hypertension sessions in churches and other areas, and in the in schools. Those models, I think, would be really beneficial in my opinion. But is there a model that we can easily replicate? I'm not sure about that.
Great, thank you. There's some really great questions coming in. I'm not sure if we'll be able to get to them all, but I believe Dr. Zafar has provided his email and is open to you contacting him. Another question is, what is your experience in considering age, so older persons, as an inequity to stroke care?
So great question again, so I'll tell you something. So again, there's some literature on it already, and if you want, I can forward you. There are 3 good publications on it. So as you know, with EVT or mechanical thrombectomy or TPA, a lot of the studies had 80 or 85. One of the studies had 90 as a cutoff, where we should be even off of it. So coming up with an evidence-based answer, and is there inequity in research for age? I would say yes. In the clinical world, anecdotally, and based on some of those studies that I'll be happy to share with you if you want, there's this question whether when we do aggressive interventions in some of the elderly patients who are on the edge with regards to their baseline, the outcomes weren't as good. And it's published in one of the studies. Anecdotally, we experienced that as aggressive sites, we like to offer EVT, and we give TPA to pretty much patients who are 98, 99 years old as well. But that is one of the things we experience post-care or post-acute care, that the outcome still is a challenge. And some studies do talk about it, and they have published some of this data. So I think it's a very good question. I think there's inequity in research. And right now, I would say clinically, we can do a better job in finding out the best ways of managing patients who are elderly. But if you're looking at patients between 65 to 80 that I don't call elderly, I call them, still young. Those patients, I feel like I don't think there's a lot of inequity in that group.
Thank you. Another question that came in was, what efforts do you think are important to encourage the reduction of risk factors in the Indigenous population? For example, work with children so that fewer will start smoking.
Yes, I agree. So I think the way I look at it, and that's why I gave the suggestion about the stroke prevention program. I mean, if you see, even getting access to the basic clinic, that's the easy answer, right? And I think the basic strategy should be that every patient, just like every kid, has to go to school. Everybody should have access to that healthcare advocate in the region, and as a primary care, as a nurse practitioner in that area, or as a clinical nurse specialist, somebody, even if it's through tele, but that should be part of a system, because as soon as that starts happening, the education is the first step into changing the mindset and changing the, and having a long-term impact. So I think in my experience, I've seen innovative funding models and other things kind of going in, that we have funding, a mobile group would go in, check the blood pressure, and then the funding runs out, and then it all dissipates. So for me, my 2 cents are that to have a sustainable model, there should be equitable allocation of resources so that we have this presence of primary care and neurologists and other specialists in those areas through tele or in person, and the resource allocation should make these centers accountable when they're getting funded, that you should do it. So really, that would make a more sustainable difference than having short-term funding things, because they've been done for the last 25 years in the US. And we still see what we're seeing here that I just presented to you today.
Thank you. So there's a few questions that we weren't able to get to today, but if Dr. Zafar is open to it, maybe I can send him those questions and he can answer them, and I can send that back to the group along with the presentation from today. So just to be respectful of everyone's time, I want to thank you all for taking time out of your busy schedules to be with us today and to listen to Dr. Zafar's very important talk. And just a reminder to please complete the evaluation for today's presentation and for the completed attendance sheet and paper evaluation forms to the email that was at the bottom of the poster. We have had a change in our March Provincial Stroke Round speaker availability due to COVID, but are continuing to seek out a speaker for the next Provincial Stroke Round, which is scheduled to be on March the 3rd. So if someone in attendance today would like to speak in March, please feel free to contact me and I will forward your name to the subcommittee. Thank you all very much and have a great day.